Medical Weight Loss Training is an online course that teaches medical professionals about the various diets, clinically proven treatment methods, and alternative diet methods available in the current market. All of our training material is provided on medicalweightlosstraining.com. Here is a sample.
The HCG diet. The popular HCG diet utilizes the principle of VLCD with hormone therapy. Human chorionic gonadotropin, or HCG, is a glycoprotein hormone produced by the developing embryo and placenta during pregnancy. Luteinizing hormone, or LH, also known as gonadotropin-releasing hormone, GnRH, is produced in the pituitary gland and has similar structure and property as HCG. Dr. Albert Simeon, a British endocrinologist, formed this hypothesis based on two groups of patients. 1. Pregnant women in India, and 2. Children with Froelich syndrome. The pregnant women in India were on a low-calorie diet due to their poverty. He noted that the pregnant women lost fat rather than lean muscle. His theory was that HCG produced by the fetus was programming the body to consume adipose tissue in order to support the pregnancy. Froelich syndrome, which is a syndrome that results from decreased levels of LH from the hypothalamus, causes obesity, growth, and sexual retardation. Suboptimal levels of LH in the hypothalamus, which contains the brain's hunger center, is associated with increased food intake. When Dr. Simeon treated his patients with low dose of HCG, he noted that his patients also lost fat. Dr. Simeon started to use daily HCG injection in combination with a very low-calorie diet on his patients who wanted to lose fat without losing any muscle. He claimed that his patients will achieve the following: A. Lose weight quickly. B. Not feel weak. C. Not be hungry. And D. Lose fat from the parts of the body where it tends to remain the longest during normal dieting, such as stomach, hips, thigh, and upper arms. The current theory maintains that HCG injection is a hypothalamic appetite suppressant. It also has adipocyte effects, as lipolysis is enhanced on an VLCD diet while preserving lean muscle. Exercise is not needed to lose fat, and some practitioners advocate against exercising while on this diet. Efficacy. The efficacy of the HCG diet is of great controversy. Journal of the American Medical Association and American Journal of Clinical Nutrition issued a warning saying that HCG is neither safe nor effective as a weight loss aid. A meta-analysis study in 1995 has found that there is no scientific evidence that HCG is effective in the treatment of obesity. It does not bring about weight loss of fat redistribution, nor does it reduce hunger or induce a feeling of well-being. It further concluded that the effects of the Simeon therapy can be attributed to the diet of 500 calories, but that the HCG had no specific effect. However, the meta-analysis did state that one study claimed the effects of HCG is that patients no longer felt hungry and or find it easier to keep the diet because they felt well on it. A small retrospective study in 2010 that reached statistical significance showed that sublingual HCG appeared to be significantly better in weight loss than a similar diet replacement diet. A recent study in 2011 on older women with androgen deficiency concluded that 3 months of treatment with twice-weekly HCG demonstrates sustained androgenic effects on hormones and muscle mass. FDA has required the labeling and advertising of HCG to state the following: HCG has not been demonstrated to be effective adjunct therapy in the treatment of obesity. There is no substantial evidence that it increases weight loss beyond that resulting from a caloric restriction, that it causes a more attractive or normal distribution of fat, or that it decreases the hunger and discomfort associated with a calorie-restricted diet. The HCG proponents will state that HCG enhances compliance and it reduces the side effects of VLCD and increases the patient's basic metabolic rate. Many practitioners will state that a patient on this diet will lose 1 to 2 pounds per day without feeling hungry, lose weight proportionally, and feel a sense of well-being. Dr. Simeon's protocol requires 26 days. Every day, 125 units of ACG is injected subcutaneously next to the belly button or intramuscularly elsewhere. ACG is available in various forms: injectable in 125 units, nose spray 250 units, or oral 500 units through a compounding pharmacy. The following dietary recommendations are given to the patients. On day 1 and 2, patients are allowed to eat to capacity whatever they want. Day 3 through day 23 of the injection, the patients begin the 500 calories diet for 21 days. From days 24 to 26, they stop the ACG injection after 24 injections, and the ACG actually stays within the patient's body for up to 3 days. The patients will continue the 500 calorie diet until day 26. After 30 days off of the ACG protocol, the treatment protocol may be repeated for one additional cycle. Appetite suppressants. Two classes of anorexic drugs are currently available: noradrenergic and serotonergic agents. Norepinephrine, serotonin, and dopamine are neurotransmitters in the hypothalamus, the appetite center, which is thought to play a role in the energy intake, energy expenditure, substrate utilization, and adipose storage. Phentermine is the most commonly prescribed appetite suppressant currently in the U.S. market. Fen-phen was a drug that combined fenfluramine with phentermine. This drug was pulled from the U.S. market due to the fact that it caused valvular heart disease. Phentermine continues to be sold as a single weight loss agent. Phentermine is structurally similar to amphetamine, which makes it a DEA Schedule IV drug and affects the noradrenergic neurotransmission. In clinical trials, the use of phentermine alone resulted in significant weight loss when compared with placebo. At the end of 36 weeks, 13% weight loss was achieved. Typical dose ranged from 30 milligrams to 37.5 milligrams per day. Typically, usage should be limited to a maximum of 8 to 12 weeks, as many studies show a tolerance. Another study looked at intermittent dosing 1 month on and 1 month off, and saw that intermittent treatment was just as effective. Typically, patients will start off with half of the 37.5 milligram tablet once per day in the morning before breakfast. Patients can take the half tablet in the afternoon if night appetite suppression is needed. However, insomnia can become a problem. Patients can increase to 1 whole tablet in the morning if tolerance is reached. The most common side effects include insomnia, dry mouth, heartburns, decreased sex drive, headaches, nervousness, and irritability. Palpitations, tachycardia, and hypertension may also occur. Phentermine should not be taken by persons with systemic cardiovascular disease, moderate to severe hypertension, hyperthyroidism, glaucoma, agitated states, advanced arteriosclerosis, and history of drug abuse. Please see the package insert for full description. Diethopropion is another noradrenergic appetite suppressant that is used. The mechanism of action and side effect profile is similar to phentermine. The starting dose is 25 milligrams 3 times a day before meals for up to 8 to 12 weeks. In a clinical trial, diethopropion at 75 milligrams per day after 6 months, patients saw a 12.3% body weight loss versus placebo.
To register, please visit or call www.medicalweightlosstraining.com 212-470